There's some interest. All right. There are some interesting age-specific trends, and we've obviously been following this type of data throughout the pandemic. At various points in time, we've seen risk greater in different age groups. So this is data showing you specifically pediatric age groups. So the first thing I want to point you to is in mid-May, you can see that divergence of our adult population and our school age population. And you can again see that decrease in detected cases in our pediatric population, our school age population. So of course, what happened in mid-May? School got out, right? So school got out, so there's probably less transmission happening in school, but we also know that there's probably less testing happening. So we track our percent positivity data for pediatric age groups along with our testing volume data by age group. And that really lets us understand whether our case detections are really true decreases in transmission or if they're associated with changes in testing patterns. If you look to the far right end of this figure, you can see that jump again in cases as we get into late August. You can see those school age groups cases went up. Interestingly enough, the increase in 12 to 17-year-olds looks like it's real. So we saw increasing percent positivity, but that 5 to 11-year-old age group, percent positivity actually stayed relatively flat. So we know that there's probably something happening here where there's probably just more testing happening. And any ideas on why we might be seeing more testing happening right now? Yeah. So some of those actually don't get, so this is going to be tests that are reported to public health. So some of those, that might be some of it. But what else could be happening as kids go back to school this time of year?
So the transmission of other viruses.
Yeah. Exactly. So we have kids that are sick with lots of things right now. And the first thing that anyone tests for is COVID-19. And so that drives our percent positivity down, right? So we see more testing happening. And what they're ending up doing is ruling out COVID when these kids have rhinoviruses or enteroviruses. And we'll talk a little bit about enteroviruses in just a second. So that's one of the things we think is happening right now. We also know that there are school testing programs. So that might be part of the reason we also see some increased testing during the school year. All right, percent positivity. So those of you that aren't familiar with percent positivity data, I feel like many of us have become very familiar with this data. This is another really important way for us to check ourselves. This is what I was talking about with that school age data. So percent positivity is a way for us to track disease transmission, but also helps us interpret increases in cases or decreases in cases and trying to understand whether that is just because of testing patterns. Testing going up would mean more cases, testing going down, potentially just because less testing is happening for some reason. And this is data that we've been tracking and using for many years with influenza. So it's data we're used to using. And one of the interesting things that we see every year with influenza surveillance is as RSV emerges, which is typically later in flu season, we see flu cases detections go up, but percent positivity go down for the same reason that I was talking about with school age testing right now, where there's other viruses circulating. So again, an important way to check our data and not rely exclusively on case level data to understand transmission. You can see the numbers though for percent positivity, again, another way to track transmission, have really been in steady decline as we've moved into the early fall in Colorado. All right, hospitalization data. So you can see that our peak in hospitalizations really occurred with that first, or not first, I guess you'd say our second large wave of illness that we saw. You can see our Omicron wave, which let's see, we got it here. Yeah. So this would be our Omicron wave there, which is actually the wave of illness where we saw the most infections, but not our largest wave of hospitalizations. Again, probably because of vaccination, immunity from prior infection, or individuals who have been vaccinated. And then also probably because we have the Omicron variants that were causing less severe disease overall. But right now you can see that we're in a pretty good place. So fairly low levels of hospitalization occurring right now. And as I mentioned at the beginning, a relative plateau the last couple of weeks in the number of hospitalizations we're seeing. Some of you may be familiar with CDC's community levels. So this is a measure that CDC came out with, I think after some pressure from stakeholders to try and represent transmission levels, not just by case data, but by incorporating hospitalization data as well, and really trying to shift the focus to surveillance against severe disease. So this is a composite measure that looks at both case level data, but also at hospitalization rates. So you can see Colorado is doing quite well here. If you look at the box for Colorado, we have just a couple of counties that are in that medium level, the vast majority of our state, with very low levels of transmission right now. Places in the country where we are seeing higher levels of transmission. This has actually shifted in recent weeks. The last couple of weeks, that concentration of orange counties has really been in the southeast. It seems to have shifted up a little bit. Now it's more in the Appalachian area. So you can see West Virginia, Kentucky, western part of Virginia are where we're seeing some higher transmission levels now. Mortality data. So this, again, I think interesting to point out that if you look at this wave here, our second wave of illness, that was really our highest peak in deaths as well as hospitalizations I mentioned a couple of minutes ago, but really our highest peak in cases occurred with our Omicron wave here, but again, less mortality associated with that wave, again, because of pre-existing immunity and changes in the virus overall. I want to talk a little bit about wastewater monitoring. So wastewater surveillance is not completely new. We've used wastewater surveillance outside of the US for a long time to look at transmission of polio, but it's actually relatively newly being used here in the US for routine surveillance for COVID-19. And there's a variety of benefits and limitations, and there's really still a lot of emerging science in how to best use this data. But some of the benefits of this type of data are that it's an efficient way to receive a pooled community sample. So trying to understand what's going on in the community without having individuals come in for testing. Also allows us to do surveillance that is independent of testing. So data for communities where COVID-19 testing may be underutilized or limited. And we do see quite a bit of variability in testing rates across the state. We know that in some parts of the state, it can be more challenging to access testing. We also know that politically in some parts of the state, people may choose to not be tested. And so this is a way for us to have access to data in the absence of testing. Also gives us the ability to capture asymptomatic cases, so individuals who might not present for testing. Also gives us an early indicator when cases are increasing. And I'll talk a little bit about why it's not the same when cases are decreasing, but this is one way for us to potentially see an increase in transmission before we see case levels increase. It can be a way for us to potentially target vaccine efforts or marketing campaigns. So trying to understand where transmission in the state could be particularly high at a given time. And then it also gives us the ability to do micro sewer shed sampling. So to try and understand transmission at the level of a building, so a dorm, for instance, neighborhood schools, also lots of potential for use of wastewater sampling. But certainly plenty of limitations as well. We, of course, are not able to, when you use watershed or sewer shed data, not able to identify who is particularly ill. We're obviously missing individuals that are part of a home on a septic system. We have no access to that waste. And in general, it's a complex and emerging science. There's really an incredible amount of variability in sewer shed virus detection levels from one utility to the next. If you think about wastewater data and how much variability there is, it's really a tremendous amount. And I'll talk a little bit about some of the modeling work we've been doing together with the School of Public Health to try and distill signal from noise in that data, but really quite challenging. Also subject to population movement patterns. So imagine a sewer shed that includes Red Rocks, right? Or a sewer shed that includes a rest stop on I-70. So, or even sewer sheds in some of our tourist communities where there at certain times of the year, there's more Texans in a given county than there are Coloradans. And that actually happens multiple times a year in some of our tourist counties. So again, as I mentioned, because of this incredible variability from sewer shed to sewer shed, you really can't directly compare one to the next. There's also variability in virus shedding. So not everyone sheds the same amount of virus. So there's much more standardization in shedding and virus detected in a nasal swab than there is in someone's stool. It can be intermittent. Some people shed more than others. And then the last thing I want to mention is a limitation in how you can interpret the data. So I mentioned that one nice thing about this data is that perhaps you can see early increases in transmission in this data. So you can see individuals start to shed virus before they go in for testing and before that increase is detected in our cases. But with COVID-19 virus shedding in stool, individuals will also shed that virus for a prolonged period of time. And so it might not be the best tool to rapidly identify when we're starting to see a decline in cases. So better on the way up than it is on the way down. All right, so this is some of the data that's on our website. And you can see on our website data by wastewater utility. So you can look at the different utilities where we have data, and there's a map where you can see this zoomed out and see all of the utilities. Here, I think we're focused on Broomfield in particular. And so what you see in the top figure is all of the wastewater detections, virus detections. And then on the bottom, you can see just a comparison to case data from that particular community to see how the two are correlating together. You'll also see there's some color coding here, indicating whether a particular watershed or sewer shed is seeing steady increases, an increase, a plateau, a decrease, or a steady decrease in the detections that are occurring in that region. And this is really where our methods and work together with the School of Public Health came into play to really try and help define how we can interpret signal from noise here. As I mentioned, the data are noisy. There's lots of random effects that go into the data, and lots of challenges in trying to interpret whether we're seeing increases or decreases. And so together with the team here, we were able to develop a Bayesian structural time series model to classify trends into each of those categories. And then for each utility, we examined the trend classification for the two most recent samples, and then classify each utility into each of these groups for us to try and identify whether we're seeing increasing or decreasing trends across the state. And so this is a snapshot from our website where you can see the breakdown, the number of utilities where we see steady increasing trends, a plateau in trends, or decreasing trends. And you can see right now, the vast majority are in plateau or decrease or steady decrease right now. All right, want to talk a little bit about modeling data and how we use this data to understand transmission. And this is, of course, work I mentioned that is in collaboration with the Colorado School of Public Health. Our COVID-19 modeling team is based here and provides updates to us on a monthly basis, sometimes on an interim basis as well, to help us understand and forecast what transmission might look like in the next couple of months. But one of the things that they also do for us is provide a monthly update on estimated levels of immunity. And this is obviously a moving target. We know that immunity wanes over time after vaccination or after infection. We also know that immunity levels are going to be reset when we have a new variant that has different characteristics and different levels of potential immune escape. And so because of that, there's some complex modeling that goes into trying to put together these estimates. The figure that you see on the right differentiates immunity against severe disease, and those are the higher level estimates. And then the lower level teal colored estimates are immunity against infection in general. So you can see that immunity levels against severe disease are much higher than overall immunity in the state. And then here they also break it down by the older Coloradan population, so 65 plus versus younger age groups. Overall, the takeaway here, though, is that we continue to see very high levels of protection against severe disease in particular. And again, really why the focus of our efforts continues to be around preventing severe disease outcomes and ensuring that that portion of the population that is not protected right now has access to treatment. The modeling team also puts together projections for us and trying to estimate what the next couple of weeks or months might look like in the state. And so this is just a really simplified version of some of the work that they do, where we're consolidating really the uncertainty in a variety of parameters that they're using. So these red bars that you see are really just showing you a variety of measures of potential projections based on those levels of uncertainty or variability and parameters that they're plugging into the model. But the takeaway here continues to be that we expect a continued decline in the amount of transmission, and this figure is specifically showing you hospitalization data at least until mid-October. So we are in a pretty good place here. And the question we had brought to the modeling team that resulted in this work was, are we going to see enough of an increase in transmission associated with children returning to school that we could potentially see a significant increase in transmission once again in the state? And their projections based on this modeling work have showed us that they do not believe that is going to be the case. And this is very similar to the findings of other modeling teams across the country. right, just want to touch on the updated Omicron booster vaccine. So FDA issued an emergency use authorization on August 31st to authorize a new bivalent Omicron-specific formulation of the vaccine for use as a single booster. Must be given at least 2 months following a primary dose or previous booster dose. And ACIP and CDC adopted this and approved the Omicron vaccines on September 1st. So the recommendation from ACIP is that those monovalent, so the original vaccine doses no longer be used as booster doses for people 12 years of age and older. These doses are now available. They're free and distributed throughout our current channels, and I'll show you some maps on how the vaccine is distributed. The new allocations became available from Pfizer on September 8th, and then I think just today is when we expected to have Moderna doses available in the state. There's also some of a language shift that we're seeing from the federal government around these doses. So referring to them less as a booster dose and more as really your annual vaccine, similar to how we talk about influenza vaccine. So time to get your COVID vaccine, just like it's time to get your influenza vaccine. Really important message that is really, I think, trying to simplify this counting of booster doses. Is it time for your third, fourth booster dose? And really just talking about an annual vaccine at this point. I think also important to note that you can receive your influenza vaccine and your COVID Omicron specific dose at the same time. So this is how the vaccine changed, and this is specifically showing you the original or ancestral type of vaccine for Moderna and Pfizer, and then showing you on the right what the updated new bivalent vaccines look like. So you'll see that there's the same amount of total antigen, but now half of that antigen is the spike protein, so BA4, BA5 spike protein, and then the other half of the vaccine is that original or ancestral component, and that's both for the Moderna and Pfizer. You'll see that the overall amount of antigen present in those two different vaccines is different, but both are now half and half. Just a quick map showing you providers across the state who have already received doses as of the 8th. And then our same community sites that you've probably become familiar with, where lots of folks across the state have been able to go to receive vaccines. All right, shifting gears to monkeypox. Do we want to, I'm happy to take COVID questions now, or should I hold them all to the end? Preference?
Let's hold off to the end, and some people are online, and we've got some questions that.
Okay, sounds great. Okay, all right, moving on to monkeypox. So the first thing I want to do is acknowledge the terrible name of this virus. So I think there is really, I mean, in all seriousness, I think some pretty terrible stigma associated with the name of this virus. WHO has a very long process that they're in the middle of now and trying to update the name of this virus. So you'll see that there are folks calling it Mpox now or MPV. We've been hesitant to really have a full shift in the name until we have a final name that sticks, because we don't want to confuse the public. But we certainly do recognize that it is a terribly named virus, and it's not even an accurate name. And I'll talk about that in just a second when I go over the history of the virus. All right, so what is monkeypox? So it is an infection caused by the monkeypox virus, which is an orthopox virus. Other orthopox viruses that you've probably heard of are smallpox and cowpox. There's even a camelpox, actually. Monkeypox is characterized by a severe rash that typically goes away without treatment. In some cases, it can lead to severe illness or death. That's more common in children and immunocompromised individuals. There are two clades of monkeypox. Clade 1, which is previously known, and this was a recent name change as well, previously known as the Central African clade, more transmissible, causes more severe illness. And then Clade 2, the West African clade, is less transmissible and causes less severe illness. And Clade 2 is actually, there's two subclades. There's Clade 2A and 2B, and it's actually Clade 2B that is now causing infections in the current outbreak. And those clades, again, are all just based on the genetic variability of these viruses from original strains. All right, so signs and symptoms, and I'm going to share these with you, but especially when we get to that the second and third bullet point, what I'm describing is our historical understanding of monkeypox signs and symptoms. On the next slide, I'm going to tell you a little bit more about some differences in what we're seeing right now in the current outbreak. So incubation period is generally 1 to 2 weeks is what we say. And that's unchanged. So current outbreak, we're seeing that same incubation period. So historically, swollen lymph nodes generally develop before rash, along with fever, pain, fatigue. We call all of those symptoms the prodrome, leading up to the period of time when an individual develops a rash. Typical rash of monkeypox follows a very similar pattern as smallpox. Starts with macules, which are flat lesions, progresses to papules, and then to vesicles, which are fluid-filled lesions, then to pustules, which are more like pus-filled lesions, and then eventually to crusts and scabs. And it's really until that period of time where all of those lesions have scabbed over and new skin has formed that an individual can be infectious. And that can be, unfortunately, many weeks. Historically, 95% of cases have lesions on their face, followed by palms and soles of feet, mouth, genitalia, and eyes. All right, so what is different in this current outbreak is that the characteristic rash has most commonly been starting in the genital or perianal areas, increasingly disseminating to other parts of the body. So we've been using this term rash, which I think sometimes confused the public, and that you can have a small number of lesions or bumps in one particular part of your body. Generally with this outbreak, it's been in the genitals, so not necessarily a widespread rash. And also different in this outbreak is the prodromal symptoms have been mild or absent in some individuals. And so the lesions can look like syphilis, herpes, even acne. We've had patients that have told us they think they just had some acne occurring, and sure enough, swab those lesions, and turns out it's a monkeypox infection. So lab confirmation is extremely important to distinguish between different rash diseases. So transmission is really anytime there's close contact for one person with a person with monkeypox infection, physical contact with those sores, bumps, or lesions, and that can, of course, include sexual contact. Touching linens or clothing of someone who has monkeypox is also a known method of the virus being transmitted from person to person. Transmission is unlikely during brief interactions without physical contact. And we spend a lot of time in the last couple of weeks educating the public and the media about how this is very different from COVID-19. And going to the grocery store and passing someone who may have this infection is not a way that this virus is going to be transmitted. All right, so a little bit on the history. So the name monkeypox really comes from the fact that the virus was first identified in a monkey colony that was being used for research in 1958. We do not believe monkeys are the reservoir species. In fact, we believe that rodents are the reservoir species. There are multiple rodents where monkeypox virus has been isolated. So starting in the 70s, the virus was first detected in humans in the Democratic Republic of Congo during smallpox eradication campaigns. As you can imagine, a lot of crossover in the appearance of these monkeypox lesions with smallpox lesions. Important to note, though, that in general, monkeypox infections are less severe than smallpox infections. From the 1970s through 2003, most of these cases that continue to occur sporadically were occurring in rural communities, oftentimes children who had contact with animals, rainforest regions of the Congo Basin, particularly the Democratic Republic of Congo. In 2003, there was an outbreak here in the US, 47 cases in 6 states. Colorado was not among the states that had cases during that outbreak, and that was through animal contact. So Gambian pouched rats were imported from Central Africa and commingled with prairie dog pets, which I don't believe we're allowed to have prairie dogs as pets any longer. But caused infection in these pet prairie dogs, which then resulted in infection in humans. Since 2017, in addition to the sporadic transmission in the DRC, Nigeria has also experienced a large outbreak. And interestingly, the age of cases historically has been children. I mentioned children contact with animals. This shift in Nigeria has been older individuals, and so potentially is associated with the transmission that we are now seeing in Europe and the US. So 2018 to 22 travel-associated cases have occurred from travel from Nigeria and Israel, the UK, and then 2 in the US, 1 in Maryland and 1 in Texas. So turning to our current situation, in the spring of 2020, multiple outbreaks reported in several European countries with evidence of community transmission. So localized transmission, not cases that were being imported from Nigeria or other countries. May of 22, Canada reported an outbreak in Montreal. Lots of media attention for that outbreak, certainly. We had individuals in the US that were exposed in Montreal. May 17th, the US reported its first case. That was a case detected in Massachusetts. And really just a couple of days later, we had our first detection here in Colorado. All right, so our overall response strategy is to mitigate transmission in communities most at risk. And I'm going to talk about this in the data in just a second. But here in Colorado, the highest risk continues to be among men who have sex with men, gay, bisexual men, or other men who have sex with men, primarily in the Denver metro area. But we have seen cases outside of the Denver metro area as well. Working to increase provider awareness, so ensuring that healthcare providers have monkeypox on their differential, especially when they see patients who fit the epidemiologic criteria, present with a new rash. Engaging and educating high-risk communities. We've done extensive outreach to our gay, lesbian, bisexual community to really engage with them and ensure that our messaging is appropriate. Even before we had our first case, we've been engaging with local community, knowing that we really did not want to repeat some of the challenges that came with the HIV response decades ago. So trying to do things better this time. Increasing access to testing, so building external testing capacity via commercial labs, and I'll show you how that has transitioned over time. And then, of course, using our state lab to support continued public health testing in urgent situations. So testing is available at our state lab for individuals that may not have insurance or to support potential outbreak investigations as well. And then, of course, increasing access to vaccination. Right, so 264 cases to date. I'll show you our epi curve. In just a second. Of those, 10 have resulted in hospitalization. No deaths in Colorado. There have been 2 deaths reported in the US. Though both of these, it's not clear if monkeypox was a contributing cause or the cause of death, or perhaps not even very closely related to the death of these individuals. They were individuals that had underlying medical conditions. Most of our cases, so nearly 80% in the Denver metro area. Outside of the Denver metro area, really cases along the Front Range. You can see 88% or so among men who have sex with men, 4.5% among people experiencing homelessness. And that's a population that we're particularly worried about because we know that there's risk of transmission occurring in congregate settings or encampments and shelters. So closely watching the surveillance data in that population. Thankfully, we have not seen any outbreaks in our population that is currently unhoused. Really, the cases that we've seen have been sporadic cases. We have had 6 cases among healthcare workers, but none of those cases have been associated with occupational exposure. So those are cases who were exposed socially that just happened to be healthcare workers. All right, so here is a look at our epi curve. So each of those gray vertical bars shows you case counts by day, and then that blue line is showing you our 7-day average trend of cases. So what I see in this figure is a propagated outbreak. You may see that pattern, right? So these distinctive waves of illness that are occurring, much like the rest of the US right now, it does look like we have seen potentially a peak, though with a propagated outbreak like this, I'm holding my breath that we're not going to see another large wave. But at this point, it does look like our most recent wave has been smaller than our last wave that occurred with a peak around August 15th. And this is really the same trend that's being seen nationally, where it does look like there are declining reports of cases occurring. Here are some age-specific trends. So you can see the vast majority of our cases have occurred among individuals 25 to 44, with smaller numbers occurring in those other age groups. I believe our median age of cases is about 35. We're also tracking percent positivity data with monkeypox. So one of the things that you'll see is that dramatic decrease in positivity right here. And that really corresponded with the availability of commercial testing. So as testing became more available, we were able to test more individuals more widely, where the pretest probability of someone having monkeypox was perhaps lower. So we started seeing a higher proportion of negatives. You'll see that overall, our percent positivity is hovering right around 20%. That is high when we think about percent positivity for something like COVID or influenza. With COVID, what we typically have called good percent positivity is below 5%. But with monkeypox, it's closer to 20%. And we think that's probably okay. Any thoughts on why overall percent positivity for monkeypox might be higher than what we would see with COVID? Yeah.
We might only be getting our tests from sexual health clinics that provide that.
Yeah, absolutely. Yep. So, yep, go ahead.
More distinctive symptoms.
Yep. Yeah, absolutely. I think both of those things. So it probably comes down to pretest probability, right? So with COVID, as I mentioned a couple of minutes ago, we have, COVID symptoms are the same as flu symptoms, are the same as rhinovirus symptoms. And so you're not sure what that individual has. That pretest probability is probably higher when COVID's the only thing circulating, right? But when other viruses are circulating, or also the other thing with COVID is asymptomatic infection, right? So there's a lot of screening testing that happens, less so now than previously. But when you're testing people who have zero symptoms, your percent positivity is going to be much lower than where you're testing someone who has epi criteria, so risk factors, plus has presented with a rash. And to be tested for monkeypox, you have to have a rash. So of course, the percent positivity is going to be higher there. All right, so this is the profile of testing as time went on throughout the response. And so you can see that in the beginning, the only testing that was available was in our state laboratory. As time has gone on, most of that testing is now being performed at commercial laboratories, which is of course what we want. We want this testing to be available out in the community. We know that we need more capacity than a state public health lab can provide in this. So we are seeing some unfortunate disparities in our race and ethnicity data. So same story that we've seen with COVID-19, we're seeing with monkeypox. So if you look here, this is a table showing you the estimated percentage of the population that falls into each of these racial and ethnic groups, the percentage of that population that is represented by our monkeypox cases, and then the percentage represented among our vaccine recipients. And so just a couple of examples here that I want to highlight. So if you look at our Black or African American community, you can see they represent 4.1% of our population. They're overrepresented among our monkeypox cases, and then at least compared to the proportion of cases that we're seeing in that community, underrepresented among the population that is receiving vaccine. And in this, and I'll show you the data here for Hispanic populations, same story here, 22% of our population is Hispanic. They are overrepresented among our cases and dramatically underrepresented among our vaccine recipients right now. And then the opposite story in our white population. So 67% of our total population, underrepresented among our cases, but overrepresented among our population that has received vaccine. And so this is why we're taking an approach similar to what we've done with COVID, where we have, we're using the buses that we have, sending buses to community locations, really trying to address these disparities that we're seeing in our BIPOC communities. Right, vaccine eligibility. So these criteria are evolving. If you're not familiar, I'm not going into much detail here about the vaccine that's available for this, but there's a vaccine called Jynneos vaccine that is approved for use for monkeypox. This vaccine is in limited supply, of course, and so we have received allocations, and so we're prioritizing who can receive this vaccine right now, with the initial focus being on post-exposure prophylaxis. That's that first bullet point there. So individuals that we know have had exposure to this virus, we want to vaccinate them promptly to prevent them from going on to developing infection, or to at least modify their infection and result in a milder infection. And then this next group are what we call expanded post-exposure prophylaxis. And the idea here is to get vaccine to individuals who we presume may have had an exposure. And then the final group that where we'll eventually evolve the criteria is into pre-exposure prophylaxis, or PrEP, which is vaccination of individuals before they've had exposures. But with these criteria, we're not there yet. We're really waiting on sufficient supply to make that transition to PrEP. But right now, our criteria for what we call PEP++, or expanded post-exposure prophylaxis, is individuals who've had multiple sexual partners or anonymous sexual partners in the last 14 days, people who've had close physical contact with other people in a venue where anonymous or group sex may have been occurring in the last 14 days, diagnosed with gonorrhea or syphilis in the past 3 months, who are already using or eligible for HIV PrEP because of the same risk factors, and people who engage in commercial or transactional sex, And then this last bullet point there is the public health criteria of anyone of any sexual orientation or gender identity identified by public health as a known high-risk contact of someone with monkeypox. Also have an important message that is really everywhere we list these criteria, which is that anyone who meets these criteria should talk with a healthcare provider to determine whether vaccination is right for them. We know that some of these criteria can be broad and may not apply to everyone necessarily. All right, I want to talk a little bit about treatment. So TPOXX or tecovirimat is the medication that is available for treatment right now for individuals that may be at risk of severe infection or have a severe infection. It is an FDA-approved medication for the treatment of smallpox, but it is not FDA approved for monkeypox. And so it's being used under an expanded access IND or investigational new drug protocol, meaning that there are lots of hoops that healthcare providers need to jump through to try and get this medication to their patient. CDC has done a lot of work with FDA to try and minimize the hoops that patients and providers need to jump through to get medication to really try and ensure that we have improved access to the medication, especially to address equity concerns that we might have. So the drug is for people, as I mentioned, with severe disease or people who might be at risk of severe disease. Some preliminary data that I'm not quite ready to show you today does show that about 30% of Colorado cases have received TPOXX. I haven't seen national data on that recently, but we know that New York has reported about 30% of their population has received TPOXX as well. So we think we're right in line there. It's not a medication that everyone needs. It's really for those specific groups. And also the data that we've looked at by age, race, ethnicity, gender identity and sexual orientation show that we really aren't seeing disparities there. So really good news that I think our frontline sexual health workers, I think, are doing a great job in getting TPOXX medication to patients regardless of particularly race and ethnicity. All right, just to briefly touch on flu. So what we are expecting this year is the return of influenza season. I'll show you some data showing what influenza has looked like in the last 2 seasons, which is not much. But the first thing I want to say is that influenza seasons are unpredictable, and we are terrible at predicting what flu season might look like because it is dependent on really so many factors. We also know that testing patterns have changed, and I've talked a lot about percent positivity and providers testing for one virus and then another virus. We often look to the Southern Hemisphere, and you've probably heard lots of news coverage recently about Australia and a severe influenza season. I'll show you that data. We know that that's certainly one source of information, but we know that the Southern Hemisphere actually did not have a universal experience when it comes to flu this past season. So again, unpredictable. We also, we expect this return to regular seasonal flu, seasonal flu, because we have typical mobility patterns, people moving about, not as much use of non-pharmaceutical interventions like masks, like we've seen in recent years. And then finally, that bullet I had mentioned earlier about okay to get both vaccines at the same time. So this is the Australia data. So you can see that red line shows their most recent influenza season. So really steep and early peak of influenza. It's also been described as a truncated season. So it actually went up and down really fast. So again, difficult to predict what that might mean for us, if anything at all. Here's just some of our historical data. So our most recent season, 2021-22, you can see that we had a little bit of a late influenza season, and that peak that you see is actually when we saw a significant decrease in the amount of COVID transmission that was happening here, probably lifting of mask use and other strategies, interestingly enough. If you look at the very bottom, you can see a purple line that barely moves off of that 0 line. That was the 2021 season where we had virtually no influenza-associated hospitalizations in the state. So again, difficult to know which of these lines we might look like this year, but of course we want to prepare for an early season and a severe season. I'm going to skip over that for the sake of time. So the scenario that we are worried about is, of course, having a peak of influenza and COVID at the same time. So peak hospital demand for COVID, you can see in the right table where we saw more than 1,800 hospitalizations. If we saw that plus something like a 2014-15 season, that could be a pretty bad scenario that would tip us into our range of scenarios where our healthcare system would be significantly strained. Again, difficult to know exactly what that influenza season is going to look like, though, and difficult, of course, to predict what COVID is going to look like. If it's BA.5, I'm feeling more comfortable, but if we see a new variant emerge, that obviously changes things a lot. All right, so briefly I want to touch on enterovirus D68 and poliovirus. All right, so on September 1st, we sent out a health alert to healthcare providers across the state, alerting them to increasing detections of this virus, enterovirus D68 in Colorado. This is a virus that causes respiratory symptoms, asthma exacerbations, primarily in young kids, but can also rarely cause something called acute flaccid myelitis. And this is a polio-like syndrome. And I'll talk about what this what acute flaccid myelitis means in just a second. But at the same time, just before this, we had, of course, that report out of New York, a case of paralytic polio in an individual. So I think there's heightened concern and need to do surveillance for polio in the US now. Wondering if the US has really now being able to, if the US is now able to maintain its status of being polio free after this detection in New York. So states like Colorado are trying to ensure that we have the ability to detect polio cases if they were to occur. So these two scenarios together are us really trying to urge clinicians to be aware of these two viruses and the need to detect them early in patients and the appropriate testing and evaluation that would need to occur. So when we talk about acute flaccid myelitis and acute flaccid paralysis, what these terms mean really, so acute flaccid paralysis is a syndrome of acute, which is sudden onset. Flaccid means low muscle tone versus rigid tone, which you see with tetanus, and then paralysis or weakness of your extremities. And then AFM is really a subdiagnosis of that, which involves imaging, so requires MRI of individuals to really try and diagnose that specific syndrome of AFM. Skip over this. But most important is this last bullet point here is that since 2014, we've seen these large respiratory outbreaks and clusters of these AFM cases occurring every other summer, early fall in the US. But this was disrupted by COVID-19. So you can see this pattern 2014, 2016, 2018, nothing in 2020, of course, because we had non-pharmaceutical interventions in place. And so now what we're waiting for is this huge surge potentially in enterovirus D68 cases, so causing asthma exacerbations in kids, which can result in hospitalization and ICU admission, and then potentially an increase in the number of these AFM or polio-like cases that we see in kids. And so this every other year pattern that we see is really based on birth cohorts. So enough kids really susceptible that the virus can get a stronghold and cause transmission. And so now with multiple years of not having a wave of this illness, we're worried about this really large wave potentially occurring. Tough to know if it's going to play out or not, but we're closely watching Children's Hospital data. They have data where they do surveillance based on multiplex PCR, and enterovirus D68 shows up as rhinovirus/enterovirus on these multiplex PCR tests. So closely watching their data. At this point, CDC is already reporting that they're seeing more enterovirus D68 detections in the last couple of months compared to the last 3 seasons. They have not yet seen increasing detections of AFM, but we know that those AFM detections, that acute flaccid myelitis is probably some sort of post-infectious syndrome that occurs several weeks after the respiratory infection. So we might just be getting to the time where we can start seeing some of these cases of AFM. We are investigating here in Colorado patients with illness that's suspected to be AFM, but have not confirmed any cases yet. That process takes a while, requires looking at those MRIs. And unfortunately, while we hope to someday have wastewater surveillance in place for both AFM and polio, it is not yet in place. And I'll take your questions.
Thank you, Dr. Herlihy. We also have quite a few people virtually joining us, and I'll start with just one question from Dr. Janich, who asks, can pet animals potentially be infected, or can they become infected and become carriers or reservoirs for monkeypox?
That's certainly a possibility that we are concerned about. And so our guidance for individuals that have tested positive for monkeypox is to isolate away from pets. We are worried about the scenario of monkeypox, being able to infect probably not pets and sustain itself with transmission, but wild species. I think monkeypox in prairie dogs, right, would be a bad scenario. So I think that is certainly a concern. And so controlling human infection is also about preventing infections.
Other questions from the group?
Great presentation. You mentioned the kind of the Nigeria outbreak associated with impact, and then the current outbreak in terms of demographics is somewhat similar as far as like older adults. When looking at the whole genome sequencing of that, are they, and can you see that with for this outbreak, or are they still big far enough apart that we're thinking they're two kind of like separate clade, not separate.
Yeah, so there's some great publications that have come out recently that suggest there probably is relatedness between the virus that was causing infections in Nigeria and the virus causing infections in Europe and the US. But there appears to be a pretty significant jump, a number of mutations that occurred between viruses that were sequenced in Nigeria and what's circulating now in the US and Europe. What is suspected was that there was probably some silent transmission occurring that wasn't detected, wasn't sequenced. And so we don't have a clear pattern of evolution of the virus in Nigeria. Yes.
You mentioned your department is working to what are some methods that
Yeah, so I think honestly, first, it's talking to the community. I actually had a meeting with the Center on Colfax and One Colorado LGBTQ plus community organizations this morning. We talk to them multiple times a week, share our communications strategies, get their input. We've done multiple presentations to the community, hear their concerns, hear what we're doing well, hear what we could be doing differently, work with them on targeted messaging. And, I think it's this really important balance of being direct and getting, risk messages to the community, but also not stigmatizing the community. And it is a challenging balance. So really trying to do that right, which I think mostly involves listening.
We have another question from the virtual audience. Most other developing countries have been conducting wastewater poliovirus testing for years. Is Colorado going to make it routine, or is the CDC going to do this in all states?
Yes, so something that we are very interested in exploring. We've had some conversations with CDC. There are no states right now that are conducting wastewater surveillance for polio. CDC, you probably heard a little bit about wastewater detections in New York. So CDC has collected specimens from New York and done wastewater surveillance at CDC based on specimens collected there. We're very interested in that. The methods are different than what we've been using for COVID-19. And I think there's also lots of important communications challenges. So just because we detect the virus doesn't necessarily mean we're going to have polio cases. So what we will likely detect would be oral polio vaccine virus. And we'd have to look closer at the whole genome sequencing to know that virus has reverted to be able to cause paralytic polio or not. So lots of challenges. And then also, is it someone passing through? Are there sustained detection? So lots of protocols to work through.
A couple more minutes.
Yeah, so I think it's, actually I don't know enough detail to precisely answer that question. I shouldn't try probably. But I do think that the data leading up to it and the antibody response, which has primarily been studied, I think, on the vaccines that were BA.1 targeted, did show, adequate immune response. I don't know if you've heard about this, but the UK went with this BA.1 version of the vaccine. The US decided to hold off and choose a BA.4/5 component to put in the vaccine to have a better match to what's circulating now. And so there's lots of bridging work that needs to be done looking at those. But I think most of the reassurance is coming from those BA.1 studies with the bivalent vaccine.
Any other questions from the room? We do have we have several other questions, but I think we have time for maybe two more. One question from the virtual group is, since we are shifting the community's mindset about COVID-19 vaccination boosters as being more of a routine flu-like vaccine, is it inappropriate for the community to perceive COVID-19 as more of an endemic rather than a pandemic?
I mean, it's such a gray line, right? I don't know when we precisely make that switch. I mean, it feels pretty endemic to me right now. So I think it's going to be with us for a long time to come. But I think the challenge is that the virus continues to evolve. And so each new variant that evolves presents a new challenge. And I think, what we've seen so far, and we're hopeful will continue, is as the virus evolves, that we won't see a virus that causes more severe disease, but we know that certainly is a possibility, and that would obviously be a game changer.
Any other questions? All right, well, it's 1 o'clock and I want to be respectful of everybody's time, but let's give a round of applause again for Dr. Herlihy.